Our final speaker before our panel discussion is Dr. Chris Newton. He's a pediatric and trauma surgeon at Benioff Children's Hospital in Oakland, California. There he serves as the medical director of the Trauma Care Center and Pediatric Department. He is the PI of the Administration for Strategic Planning and Recovery's Pediatric Disaster Center of Excellence, RAPIM, which stands for Western Regional Alliance for Pediatric Emergency Management. He's one of the 4 PIs of the Pediatric Pandemic Network, and his presentation is entitled Lessons Learned from the 2022 Pediatric Viral Respiratory Surge, the Intersections of Infectious Disease and Pediatric Emergency Management.
All right, welcome to, I think this is the last of the lectures before our panel discussion. And I have been assigned the task, I think, of putting this all together. And all of the different lectures that you've now heard, how do we synthesize this into the past 3 years? What have we learned? And where are we going from here? So it's an overwhelming task. Thanks, guys. I also, this is standard disclosure statements that you will see on almost all of those, but I want to stop one moment and make a point for this part of the talk in particular. These are my views, and I need to say that because wrapped up in this discussion is some uncomfortable statements. And that's just the truth of where we are. So, I will go over a lot of the both COVID and surge and how the different organizations engaged, what we learned, and hopefully get to the point of at least giving an overview of how we view preventing this from happening again in the coming winter. So, I'm not going to talk a great deal about, the pediatric gaps and needs. You've heard that. And I think this is preaching to the converted. I will highlight, in looking at the gaps and the needs, a few interesting elements. So yes, pediatrics is 25% of the population. However, our healthcare system has become very concentrated in pediatric high-level tertiary hub hospitals around the country. That's fantastic on a day-to-day basis. Kids get incredible care transferred in. However, there's been a bit of an erosion of pediatric capability across the entire landscape. And you've heard about it in a lot of the other talks. Also inherent in pediatric perspectives and disasters. In any event, when the children are affected, there are ripple waves that affects everything else. And you can look at this from the basis of access and equity, from schools, from loss of employment hours for parents who have to take care of their kids. The 25% of the population is misleading when you begin to think about impact. All right, so please, I don't expect anybody to read the details on this slide. That's not the point of me putting it up. This is where we began. So this was in 2019, the RAPIM and Region 5 groups, the ASPR COEs, began responding to COVID needs. And this graph was just showing multiple events over time where we were asked or got engaged in different problems, and over and over and over again, the problems were something we had never seen before. No one had. This was all completely new, unprecedented, and we had no science and no data and no way to figure it out. So for each one of these, we had to get creative. And this is where it began. So this is an example. That's one of these points that was on the graph. So this particular, episode was trauma centers and surgeons around the country asking, this strange COVID thing has now come up. We know nothing about it. What do we do about appendicitis? how do we sterilize our trauma rooms and turn it over and maintain capability after a COVID child has come through? Well, what about anesthesia and what's appropriate mask? There was a period where none of this was known. And yet there was panic in the healthcare system, and everybody needed an answer in a week. There's no way to get data. So this was, instead of a PDCA cycle, this is a do cycle. And the check and planning will come later. This is reality. So we set up a platform and said, everybody around the country, come onto the platform, come onto this Google Sheet and put on, what are you doing in your center? And let's all just talk to each other and figure out who's got good ideas. And believe it or not, everybody did this. They went on and put on this is how we're taking care of appendicitis. And yes, in a week, no data, establishing a community standard of what are we all going to do together. So I'm so sorry, Cinnamon. This is the first of the uncomfortable statements. Bad science, but meaningful. And this is where you start. So this was next example that I'll just illustrate. So several months after that, bed capacity, trauma systems, EMS systems, adult and pediatric were getting overwhelmed. There's no beds anywhere. And many local communities, states entered what's called contingency standards or crisis standards. But crisis standards, been academically written about and validated. NASEM has done this amazing work over the past 10 to 15 years to define this. But for kids, that's not defined. So we, once again, were faced with questions from around the country. How do we do crisis standards for children? Because that's not part of the academic profile to this point. So once again, in the moment of need, we designed a platform to have town halls. Teamed up with ASPR and others, went region by region, let local communities get on and have an open forum to talk about how are you guys dealing with this? And collected various ideas from around the country and put them on a big graph. Once again, please don't read this. This is just an example to show you what we did. Put all the examples of here are your options, because we've seen this work in different areas of the country. Highly successful because it equalized the system playing field across lots of different regions. Okay, so you've already heard about PPN and the structure and how it was developed. I'm not going to repeat all of that. I will just highlight the obvious. Inherent in PPN infrastructure is this infectious disease domain. So when we began this conceptually, we wanted to organize a high-level think tank. So an advisory board that had representation and voices from AAP and the CDC and FDA and the journals and epidemiology. And we wanted to do that because there was a little bit of an erosion of trust at this moment when we started. At that time, there was public mistrust of messaging coming from everywhere because it was confusing. So all of the ID experts around the country that I talked to just jumped on this with passion. And this was fantastic. The group actually came together. Then the task was, how do you take their messaging and deliver it and get it to the communities that need it the most, especially the communities that have disproportionate resources and disproportionate needs. I think we're still working on that piece, but it is foundationally part of the vision of putting it together. All right, next event was the perfect storm. So this was, as many will recall, last fall, winter, began in early October, went through December. So at that moment, there was a viral surge, respiratory viral surge, RSV, influenza, COVID, and each of those surges from CDC numbers was not individually overwhelming, not compared to what you would look at annually. But when you combine all three of them, it was a significant increase in demand of pediatric intensive care beds. When you add to that demand a mental health crisis and suicide attempts, in our ERs, and then you add to that a significant decrease in pediatric nursing across the country at hub hospitals, and then you add to that community hospitals that have had an erosion of pediatric services because many of them couldn't maintain it throughout COVID. You put all those pieces together, and the end result was the unprecedented and unthinkable. The pediatric healthcare system was frozen. And that system is foundationally dependent on patient movement. But no patients could move anywhere. That's the catch. It was every hospital, not just a state, not just a community, it was all of it. So what we saw was every community needing to prioritize the sickest kid and can we find the most acute that needs the bed and match the need and the resource, move the ones that really need it, and at the same time, try to support the kids who are waiting in line. So that experience is what I would define as contingency care. Now, contingency care, we can have arguments about the verbiage and the definitions, but I'll give you mine for sake of this discussion. What this means is doing unconventional things to maintain adequate care. Might not be ideal, might not be what we all dream of, but it's good care for everyone. That's contingency. If you get into the point of there's individuals we can't take care of, that's a crisis. That's a different step in the hierarchy. So I think most places were in contingency state in the US at that moment. And so the theme that I was illustrating through COVID popped up again. So, okay, how do we, in immediate fashion, find a best practice? And what are the good solutions? So we revived the town hall exercise. PPN and the COEs and ASPR and HRSA and CDC kind of all banded together to host these. We went to every region. Most of that were here got involved in one of these, and this was sharing time. This was, what other problems are we facing locally in our state, in our region? How are we dealing with it? And who's got good ideas to share? So highly successful. Some of the common themes that came out of that was this, the third bullet point here, and that was everybody was trying to do better when it came to identifying the open beds and the kids that had the need and having control and coordination. So this is dashboard. This is what we call situational awareness. We know where the need is. We know where the resources are. We have some kind of central infrastructure that makes sense, that helps get the kids to that. And if we can't, then that centralized infrastructure provides clinical guidance or telemedicine, or connects the child who's waiting in line with some kind of resource. So this is what everybody was trying to do. And clearly, there's some areas of the country that were really impressive with this. They did a really amazing job of developing this capability really fast. Some areas struggled. And this is one of the areas that we need to do better over the next year, because if we don't, next December and January is going to be tough. The other bullet point up here was interesting. And this was my next uncomfortable statement. How do you take evidence-based, good, standardized, treatment algorithms that have been vetted at the highest level nationally and are solid? Can you take those and utilize them in an unconventional setting that they weren't designed for? So the ask was this: every community adult hospital began asking us, well, if I've got a child in my adult ER, I don't have a pediatrics nurse, I don't have a PICU, I can't transfer the kid, I'm frozen, kid's stuck in my ED. How do I deliver oxygen with high flow and monitor the child and keep the child safe? How do I identify when that child needs, emergency transfer? This is uncomfortable because in a normal state, we would say, no, you cannot do that. That violates everything that we normally do. You have to be at a children's hospital. But since that's not an option, we translated everything that we do in the children's hospital as best we could into a treatment algorithm that they could do in an adult ER. This is how you set up high flow oxygen. This is how you begin the monitoring, and these are the steps that you take. And we put together a video so that people could see this is how you set up the oxygen and the equipment you need. This was fantastic, and this was, many people throughout all of our PPN systems and COEs all kind of banded together to put this document together. And then when the ask came, the group, it took about 72 hours to take all of the best practice and consolidate it into this one document. So it needs to be vetted now. Now it's time to check and collect data and make it better. And this is unconventional, but this is how science is going to have to work. All right, so this is an example. You saw this. I think Dr. Beer showed, little examples of this. And once again, this is just up on the slide as illustration. So, and I talked about this a moment ago. Every place around the country was having struggles with dashboards, visibility. Where are the hot spots? Where are the open resources? And coordination. And and I will call out, Washington State, for example. Their pediatric mock system that they have coordinated to overlay as a safety net to their normal day-to-day operations has been fantastic. And and their state legislature, the governor has decided this is so good, we're going to keep this going. We're going to fund this as long-term infrastructure. That's a success story. There's some of us that are still working on this, and it's clearly one of the priorities for PPN as well, to invest in how do we build a template that can be used across different systems, because it's a big need. All right, once surge was over, so this is January and February of this year, every level around the country began looking at the past 3 months and talking about what did we do well, what did not go well. This is after action reports. And all of the discussion is focused on our system has been exposed for having some deficits. And we know surge is going to happen again next winter. So we got 9-10 months here to try to talk about how to make next winter different. So this happened at local levels, hospitals. Kaiser as a system level did it, as, for example. The PPN has done this exercise. Each of the COEs has done it. All of these have been as well shared with HRSA and ASPR. And I think ASPR is putting together, an evaluation of the town hall experiences and lessons learned. So this has happened all over the country at lots and lots of different levels. So let me give you my personal summary of all of these discussions. I think, is this going to go? Here, let me just, oh, it wants to restart. I think snooze. Okay, good. There it goes. All right. Okay, here is the executive summary of a lot of different discussions that are very complex and very deep. So I have consolidated a lot of those into buckets of issues. Issue one is maybe one of the most significant. There's a pediatric healthcare infrastructure rebuild that is needed. And this is not just at the pediatric hospitals. Yes, we need more pediatric nurses. True. This is in areas that, kids have a tough time accessing pediatric care. This is, rural and community hospitals and receiving hospitals. So this means re-education, reviving pediatric practices that maybe used to have been there that aren't. This means ramping up the Peds Ready program that is going out to community hospitals and trying to maintain a base level of pediatric care and tying that to the trauma systems and having education that is constant and having those centers all connected to the pediatric hubs and infrastructure so that they're supported. So this is, I think, immediate steps that need to happen, and it is already happening kind of all across the country. And this is going to be a work in progress for a while, because I think we have a lot of work in front of us to do on this front. Bullet point 2 and 3 there is those dashboards that I was talking about and the coordination that I was talking about. And I'm not going to reiterate what I've already said. There's places that have good examples that were very successful on a local and state level. So when we start talking about counties and and healthcare coalitions and states, this is where the work is going to have to happen of how do you roll out and implement the IT solutions to be able to identify the resources that you have, the kids that need those resources, and how to coordinate moving them without interrupting day-to-day healthcare business practices. So it's a complex issue. There are legal challenges and cooperative challenges involved in those difficult discussions, but they are happening. And at various places around the country, I would expect this to get better over the next 6 to 9 months. It will. I gotta believe. All right. The next on that list is ancillary clinical support. So ancillary clinical support means telemedicine programs, outreach programs to those community hospitals. If I tell a community hospital to have a Peds Ready program at a PEC, is that PEC educated and empowered and connected to be able to get all the things that they need? So this is support also from those uncomfortable algorithms that I was talking about earlier. Okay, we put it on paper, but can I make that evidence-based? Can I change that, that uncomfortable document into something that we all trust, that is viable and valid long-term at community hospitals? This is clinical support, and it encompasses a lot of things. And I think a lot of the different domains in PPN are touching pieces of this. And I think all of it is needed. This is how you pull together the big picture. The telemedicine group is doing a lot, working both within PPN, but also with the ASPR COEs and the RDHRS groups, and the national CTN network. Mental health, as you have already heard, is also kind of coalescing into this amazing national community. And I think that is a piece of getting those kids taken care of so that the system can never get frozen again, because we can't let that happen. The final piece up there, I'm not going to mention. I put it up there for notation because it has been talked about a great deal on a lot of these AARs, and that is pediatric equity and the reciprocity for CMS payments. If it's very, very expensive to maintain pediatric programs in rural hospitals because there's a difference in payment between adult and pediatric, that's a barrier. And so, like I said, I'm not going to that's a controversial topic. I'm not going to get into it, but I have to put it up there because all of the AARs called it out. All right. So in my last moment here, in the coming year, a large part of PPN infrastructure build, so education support, rests on knowledge, education, communications domain groups, developing all of those resources, putting them into a consolidated repository that is available. This is in process. Tremendous investment we have made into developing this, and it's getting there. It looks good. This also means a heavy lean into the PEDS Ready program. So this is tying, of course, PEDS Ready is an EMSC program. That EMSC program is critical to PEDS health infrastructure around the country. It needs to get more robust, and part of the robustness is us as pediatric hub hospitals supporting the efforts of the community hospitals in elevating their game. And I will say one of the trauma group's efforts in PPN is mobilizing this for trauma centers. So American College of Surgeons has now mandated PEDS Ready is going to be part of validation of a trauma center. This is adult trauma centers from level 3 up. This means everywhere around the country that takes trauma now needs to go through this exercise and try to have a pediatric care champion and make sure that their ERs are stocked and staffed. So a lot of our efforts in the trauma systems group is empowering that and trying to help those trauma hospitals to do this honestly and try to improve their hospitals. I will note the ID group is of course doing so many things, but they have evolved to looking at several pillars of projects, and among them, for example, is unifying special pathogens discussions around the country, as well as doing surveillance and looking at vaccine hesitancy. And vaccine hesitancy is a complex issue, but I'm grateful they're gonna take this on. Because it also includes that discussion. It includes equity and community engagement and what that means in different areas of the country. We got a lot of work to do in front of us. So I think we've got a good start. I think the PPN infrastructure is fantastic. I am grateful for all the people that have, invested their hearts into this. It's an amazing endeavor, and we've come a very long way. So thank you very much for letting us all talk about all the things that we do.